My name is Henry Wong. I'm currently practicing based out of the San Diego Veterans Hospital. I'm also a clinician practicing at UCSD School of Medicine, and I also take care of patients at the Moore's Cancer Clinic, taking care of patients with cutaneous T-cell lymphoma. So the natural history of CTCL is complex. It's a very heterogeneous disease. So when we talk about CTCL or cutaneous T-cell lymphoma, this is a fairly rare non-Hodgkin's lymphoma. The most common variants that we focus on the mycosis fungoides and the Sézary syndrome. And they constitute, 60 to 70% of patients with CTCL. This is a subset that has common behavior. They originate from a subset of T cells called CD4 T cells. And they're the most common type of T cells that give rise to CTCL or the mycosis fungoides and Sézary syndrome. The other subsets are the other 30% arise from other non-standard T cells, much more aggressive, and we have less good treatments for them. For mycosis fungoides and Sézary syndrome, have been able to learn a lot from them. Dermatologists have recognized it over many years and have at least gained an idea of how it progressed. Generally, it starts on the skin. The skin is an important immune organ, and when you have immune cells that become abnormal, it can cause reactions that are unusual. I mean, the skin is important for protecting the body from bacteria and whatnot. Abnormalities of the T cells or immune system can cause a lot of rashes. And so one of the challenges that we do see in CTCL is that as it develops, it can mimic other non-cancer inflammation, such as atopic dermatitis or psoriasis. So those are types of skin disease caused by T cells as well as other cells, but T cells play a role that can cause inflammation. So that's the immune component. So when you do have some cancerous T cell in the skin, as dermatologists, we're able to see it directly and we can recognize it. And so often it starts in a localized area. Most common locations that we mention is that it develops in the bathing trunk areas where the sunlight doesn't really hit it. So it expands slowly over time. Now, we're able to see it, and when it has a distinctive features in combination with a skin biopsy, we can then accurately make a diagnosis that it's a CTCL. Because it's on the skin, as it gets more advanced or more involved, it expands to affect greater and greater part of the skin. So in this cancer, what I often tell patients is that as it gets worse on the skin before it gets to internal parts of your body. So, unlike other skin cancers such as melanoma, that can be a very insidious cancer. It can spread and we can't tell where it's going. But in general, with the CTCL, when patients get worse, it expands on the skin before it gets to the lymph node and it gets into the blood. So we're able to monitor the progression of the disease by looking at the skin. This progression is not aggressive. In general, we call it an indolent lymphoma. In most patients, it can take many years for the disease to involve more and more of the skin. And so what that means is, in terms of treatment should be directed to the skin, or treatments that don't have significant systemic effects early on. As it progresses through more advanced stages, the way we often see CTCL and mycosis fungoides advance is that it gets thicker lesions, it develops into tumors, it develops lesions in greater and greater parts of the body surface area, over the trunk, buttock, back, legs, and it can also affect the head and neck as well. Beyond that, when the tumor burden increases to a certain point, malignant cells also can affect the lymph node, and at a certain point, there's cells that can also go into the bloodstream and can get into a leukemic stage. I mentioned that the most common variants are mycosis fungoides and Sézary syndrome. Sézary syndrome is a variant of CTCL, also caused by CD4 T cells, and this variant is a variant that involves this extensive amount of the skin, also has lymph node involvement, but it also has blood involvement. This variant can develop from mycosis fungoides as it progresses to more advanced state, or sometimes in a subset of patients seems to, what we say is it arises de novo, meaning that it just arises fairly rapidly. It develops over months. Patients get red, lymph nodes get enlarged, they have blood involvement, they have very itchy skin, like a severe eczema patient. And these patients get very sick. So that's a variant that, is characteristic of Sézary syndrome, and it's part of the CTCL group of disease. Multidisciplinary treatment is very critical because these are patients that can have various stages of disease, and it's important to have dermatologists as well as oncologists as well as radiation oncologists participate in the care and get experience and understand how patients respond. Also, patients have skin involvement. More advanced patients have more internal involvement, systemic involvement, blood involvement. So that's one of the major reasons where multidisciplinary care is important. Dermatologists have skin-directed treatment, phototherapy, and skin-directed treatment is valuable and important in caring for symptoms from these patients at all stages of CTCL. In terms of patients who have poor response to topical treatment and who need more systemic treatments, they're not responding well to the first-line treatment. Systemic treatment's important even in fairly early stage, and that's where I think collaboration with oncologists is really valuable. We have oral systemic agents, but also we now have very new targeted treatments where I think oncologists play an important role. And then certain lesions, tumors that can cause significant discomfort, that's where radiation oncologists play an important role, and they can treat these lesions, and it can make a big impact in the life of patients with CTCL. And this is present a lot in comprehensive cancer centers. Going back to just the natural history of this cancer, it's slowly progressing for a lot of patients. What we have learned, and actually many decades ago, that one thought was to treat this cancer with aggressive chemotherapy to knock it out, and maybe we can get a cure. And there were many papers published that showed that patients with different stages of CTCL, from early stage to more advanced stage, they got combination chemotherapy with radiation compared to patients who were treated with just very conservative skin-directed treatment. And what we found is that actually survival was not any better in those patients who had chemotherapy compared to just really very conservative skin-directed treatment. So we learned a lot from those early studies, and that supports that chemotherapy is not effective. Now, what that tells us, I would say, is if we look at the pathology of patients over time, if we biopsy patients with early stage disease, we can see abnormal, the neoplastic cells in the upper layer of the epidermis. But what we often see is also a robust CD8 T cell response. So there's a lot of inflammation, and that's a component of what we can probably suggest is tumor immune response. And so early on, one of the reasons why the natural history is likely slow is that there is a tumor immune response that we can see on the pathology. And so what that also implies is that chemotherapy is not an ideal treatment, particularly early on, because combination chemotherapy actually affects the bone marrow, affects the immune response. And what we see in specialized centers that patients may have gotten chemotherapy and then the disease will progress actually faster. And so chemotherapy is not a good treatment. I think patients need to get treatment from experienced clinicians. The treatment should be tailored to the stage of the disease, to what the patient has experienced in the past. And ideally, patients should get treatments that augment the immune response if possible. And then now, I think with our research and advances in understanding, the cell types that are abnormal in some of the surface markers, we have now some targeted treatments for CTCL that has a lot less side effects and has a major impact on the patients with CTCL. Some of these include a certain subset of CTCL patients express CD30, and so there is a targeted treatment, that targeted antibody that targets CD30, and that's been able to make an impact in those who have tumors. We say that who we have observed may have transformed CTCL. Another subset of another marker that I think we have learned that's expressed on CTCL T cells are as a CCR4. This is a marker expressed on the Th2 T cells, but it's very frequently expressed on the CTCL T cells. And so that's been a targeted treatment that is well tolerated, targets the neoplastic cells, and has been able to make a big impact in treating patients with CTCL. And each drug has its own benefits. I mentioned CD30. It's more effective in patients with tumors, but the other subset, Sézary syndrome, what we've found is that these cells do not express CD30, so that anti-CD30 is great for transformed CTCL, but not for those with Sézary syndrome or other non-transformed CTCL. And then for what we've seen with anti-CCR4 is that this is a marker that's expressed on the CTCL cells, and CTCL. Mycosis fungoides may have extensive skin involvement. Some will have cells that get into the blood. And then, of course, there's a variant that's Sézary syndrome. They all generally express CCR4. And for patients with blood involvement, anti-CCR4 is highly effective, and it can reduce the blood involvement very effectively. And then we've seen that in our experience, and that doesn't affect the immune system like chemotherapy, and is more targeted, and it has a benefit in that regards. In oncology, one approach to treating cancer is to have combination treatments. And although a lot of the therapies are approved as monotherapies from clinical trials, once they are approved, combination treatments can be very helpful to enhance the efficacy of the drugs and get a greater response for our patients. And treatments that have been around for many decades, such as bexarotene, retinoids, that's a very useful treatment for CTCL. And that can be combined with the targeted treatments for treating patients with CTCL. So I think there are a lot of options in terms of treating patients with CTCL. I would just recommend an approach where we try to enhance the immune system, use targeted treatments, avoid agents that suppress the immune system. I know the sort of incidence in the US, it's, I think 3,000 new cases per year. I think because it is a more indolent cancer or lymphoma, the patients affected by CTCL is much higher. So there are a lot of patients in this country and across the world with CTCL who have the disease and who need treatment to control the disease to prevent it from progressing. And then in terms of the cause, we still do not understand exactly what is initiating agent. There's a lot of excellent publications looking at the genetics of the abnormal cells, and we've found a wide variety of mutations, but no really specific mutations that is a cause for CTCL. Because one reason is that it may be a rare disease, and we just haven't looked at enough patients. So that I think more work needs to be done on that regards. And then in terms of the demographics of the disease, what we have seen is, and I can't fully explain that the reasoning for why that's the case. But there seems to be some geographic preferences that we've seen across the country. I mean, we see higher in the South, in Texas. We see some in California, and then I think some of the major centers, definitely get a lot of referrals. So we see recording higher numbers around New Haven and Boston and Pennsylvania. In looking at the distribution in Arkansas, we practicing there, looking at the number of patients, we did see a fairly, I think, a disproportionate number of patients relative to the size of the population in Arkansas. That may suggest, some regional disequilibrium. Some of the areas do have, like Texas, there's a large sort of industry for petrochemicals. I mean, it is possible that, we probably can't identify a specific chemical, but that may increase the risk. And I'm just speculating there. But we do see, in one of our papers, we did see increased association of patients around in major highways, which may be due to exhaust. So chemicals likely play a role in this. Exposures increase the risk of this. Another observation from looking at the demographics in the U.S. is, the population that may have increased risk is the African American population. So we do see a slight increase in the incidence in African Americans compared to Caucasians. And some of the patients, what we've seen is they present younger and they have a more aggressive disease. So that's a subset of patients that we need to monitor and be more vigilant in terms of making sure we diagnose them earlier, follow them, and making sure they get the appropriate care. I think one area that I can talk about, I think it needs additional research, is we need a better marker for diagnosing patients and differentiating those patients who have mycosis fungoides, CTCL, from others inflammatory skin disease, such as atopic dermatitis or erythrodermic psoriasis. It can be difficult to differentiate them. So we need better diagnostic biomarkers so that we can treat patients who have CTCL with therapies targeted to CTCL. And we don't want to have patients who have CTCL get immunosuppressants that we would normally use for psoriasis and atopic dermatitis, because that may accelerate CTCL. And then on the flip side, we certainly don't want patients who have psoriasis or atopic dermatitis to get treatments for CTCL. So we definitely need better markers to differentiate and make a diagnosis of these a subset of challenging cases of CTCL earlier. The other point that I would like to add is, and we're studying that, I think, is one aspect of this disease is that it does progress slower than other aggressive cancer. And when we follow patients over time, I think a challenge for us is who are the patients who will progress, who will transition to a more aggressive stage. Currently, we don't know. It's hard. And if we have better insight and a better marker, that may be predictive, then we may, those are the patients that we can treat with more vigilantly. We can do studies to develop treatments that may, slow down the progression or even, prevent the progression. So I think those are areas where I think we still need to work on, in addition to, just more treatments, because one other point of this disease is it's very, very heterogeneous, and there's no one perfect treatment for all our patients.